Good afternoon, all of you. It's an honor and pleasure that in today's CME we have an eminent guest and speaker from Tata Medical Center, Kolkata. His name is Dr. Mayur Parihar. Dr. Mayur and me, we go along, I think, 7 years back. That the first time I visited him and did a short training for molecular pathology at Tata Medical Center, Kolkata, under his able mentorship. Dr. Mayur is a renowned name. He doesn't need an introduction, honestly. If you go to Southeast Asia and also in the US, he has several publications and chapters. The recent one being on ALL, with the focus of cytogenetics and molecular pathology in the WHO latest edition. Dr. Mayur is also the head of molecular pathology of Tata Medical Center, Kolkata. He has a very great team over there because I have worked with them for a short span of time. And I would actually attest everybody of you that you can visit the center, and of course he will be happy to train our people when we visit over there. He is also the organizing secretary of the Molecular Pathology Association of India. Our next Molecular Pathology Association of India conference is in February in the same town, Kolkata, and he is the organizing secretary for the conference. So I would like to welcome Dr. Mayur. This is a brief introduction I can give about him, and maybe he can take it up from there. Welcome, sir.
Thank you. I think I have this. Okay. Yeah, I'm audible. Thank you, everyone, and thank you, Dr. Rao, for inviting me. I was visiting Kenya for a conference on next generation sequencing, and then he said I must come here. So Dr. Rao, visited us a few years back for a week-long workshop that we do. And he's always shown a lot of enthusiasm and interest to kind of, develop these facilities in this part of the world. And I've told him that we will offer all the support he and the team needs to develop anything he wants to develop here. So without much ado, I'll just start. So what I'm going to do in next half an hour is give a brief overview as to how we have been using molecular pathology in breast cancer. So when we were discussing about the topics I could speak on, and so Sundar was that since October is breast cancer, can we make that slideshow mode? No? Okay. Because it's a breast cancer awareness week, so he said, let's talk on breast cancer. So I was like, sure. Okay, so I'm sure all of you know that breast cancer is the second most common cancer in women worldwide, and it's a very heterogeneous group actually. If you see, there's significant heterogeneity, and although there are treatments that are available now, how does molecular pathology actually integrate into the care of breast cancer patients? So what it does is it guides the prognosis. So you have a lot of prognostic markers which will help you take a call. So there are biomarkers that are both prognostic and predictive of outcomes. Precision medicine, you identify targets that can be targeted. It predicts resistance. So there are markers which will give you an idea whether this patient is going to respond to chemotherapy or not. And there are different scores available for that. And then, of course, personalized targeted therapy. There are targets that can be identified, and those targets can be actually targeted using targeted therapy. So whenever we look at biomarkers in the lab, you can look at it, I'll just go back to certain basics like the central dogma of molecular pathology. And you can have a biomarker being identified at a DNA level, at a RNA level, or at a protein level, right? After all, it's a DNA that converts to RNA and RNA that converts to protein. So let me, and so what are the various techniques, right? So whenever you look at a marker at DNA level, you can do FISH, right, in solid tumors. For liquid tumors, we do karyotyping. We can do mutational studies there, looking at different mutations, and we can do copy number abnormalities. mRNA is the messenger RNA. You use mRNA for fusions, for looking at gene expression, and you'll see that some of these can be, the gene expression studies are done, and then you can look at protein. So let me give you a simple example of HER2. So HER2 is a transmembrane protein. We can look at it at a DNA level using FISH, which is fluorescent in situ hybridization. There are a lot of people who have done real-time PCRs to quantify the mRNA levels of HER2. It's very cumbersome, and that's why it has not come into clinical practice. And the same HER2 as a protein, we look using immunohistochemistry. So any biomarker can be looked at DNA level, can be looked at an mRNA level, or can be looked at a protein level. Now, when you look at the evolution of and management of breast cancers, it's really evolved, right? It started only with histopathology. Then immunohistochemistry came, and we were able to look at hormonal markers like the ER, PR, and patients could be treated accordingly. Then once there was genomic profiling and TCGA, then you can look at various other markers. Genomic assays for targeted therapies, you can look at various mutations that can be done. And then now we have precision oncology, which has become an integral part of treatment in breast cancers. So what are the molecular biomarkers you do? So as I said, first hormone markers. One must also understand every histopathologist is also a molecular pathologist, because at the end of the day, when a histopathologist looks at morphology or looks at immunohistochemistry, and when he's doing immunohistochemistry, he's actually looking at an aberrant protein or a physiological protein expression of the molecular changes that are happening. So a lot of molecular pathology can be done through immunohistochemistry as well, because that is where you're looking at a protein expression. So we have the hormone receptors, ER, PR, of course, HER2, I'll talk about it, Ki67, and then the BRCA mutation, so hereditary risk for developing breast cancers. And we also look at somatic BRCA mutations, because these patients respond to PARP inhibitors. Then nowadays we have started looking for PIK3 mutations, because there is a drug that targets PIK3A. Now some of these drugs, in targeted therapy are very expensive, right? And some of them are not available in India also. So what we have done is, in our hospital, we have developed a compassionate drug-based program, wherein we contact these pharma companies, and there are patients who are resistant to all kinds of therapy. The pharma companies, on a compassionate patient-to-patient basis, transports drugs, these expensive targeted drugs for the patients. So I was joking, we do have a refrigerator in our hospital which has drugs worth 300 crores, right? There are vials worth 15-20 lakhs. So anybody can just walk with in the pocket and walk out of it. But what I'm trying to say is, it has taken a lot of effort, and we have designated people, and I think it's a very good program to have a compassionate drug access program in any hospital, because there are a lot of targeted drugs being discovered every now and then in Western nations, but we do not have access to them in where there are constraints in resource. But when you develop a program like that, patient to patient basis, they do have and you can actually get access to this PDL1 expression. And now you also have a lot of multi-gene assays like the Oncotype DX, MammaPrint. These are very expensive tests, and these actually kind of predict whether a patient would respond to chemotherapy or not respond to. So in India, if you have to do an Oncotype DX, it costs 2.5 lakh Indian rupees. So there are such expensive drugs. But if there is a young breast cancer patient and a call has to be taken whether she would require chemotherapy versus not require chemotherapy, it gives you a more objective, informed decision you can take whether the patient would require chemo or no. And for a young patient, it is very important if chemotherapy could be avoided, because the long-term side effects of those chemotherapeutic agents are avoided. So hormone receptor, I don't have to go into much details of it. You do have ER positive, PR positive, that's favorable. These patients respond to hormone therapy. Then you have the intermediate risk, and then we have the ER, PR negative, right, where other chemotherapy is offered to these patients. Now coming to HER2, right? Now what is HER2, right? So if you look at the biology of HER2, it is a family of human epidermal growth factor receptors. Now these are receptors that are present on the cell membranes. Now there's HER1, HER2, HER3, HER4, and so on. Now each of these receptors has a ligand, and whenever a ligand attaches to this receptor, it activates these receptors and result in downstream signaling, and cell proliferation. But in HER2, there is no known ligand that has been identified. So how does HER2 work then? So what happens is, whenever HER2 is amplified, right? So we look for HER2 amplification. At a protein level, we look at immunohistochemistry. So what happens is, when this number of HER2 receptors increase in number, as you can see, they start crowding the cell membrane. And once they get in touch with each other, because now there's crowding, right? There's no ligand coming. There's no mutation in the HER2 here. It is just the number of receptors have increased on the cell membrane. They start crowding, and when they start touching each other, it results in dimerization. And that dimerization results in potential signaling downstream activation and cell division. So a HER2 positive patient will have more proliferative breast cancer. But why it has become important today? Because we have Herceptin, wherein this can be targeted and patients respond to therapy. So the HER2, the receptors not only dimerize with homodimerization, but there is also heterodimerization. So they dimerize with even other HER receptors, and that results in activation of potential pathways that results in increased cellular proliferation. So as I said, it is both prognostic and predictive. We look at IHC, 0 is no staining, and then we have membranous, and we have, I won't go into the details, 1+, 2+, and then whenever it is 2+, that is when you're not sure on IHC whether it is positive or negative, we fish for them, right? That is fluorescent in situ hybridization. We look at a DNA level for increased copy number of the HER2 gene. So this is how it looks. If I can point it out here, yeah, okay, you can see this is HER2 positive. You can see it's a transmembrane, and this is the fish counterpart, wherein you can see the red is, these are the blue is the nucleus here, and the green is the control probe, and the red is what goes and hybridizes to the HER2 gene. So normally you will see 2 red, 2 greens, because you have 2 copies of a gene in any cell. And here what you can see is it's completely amplified. You can see there's a whole cluster, and that is how we look at fish. There are criteria to actually count, and how do you count and how do you interpret the fish signal. Now, a basic issue is there is a lot of issue about the tissue, right? So whenever we do have because we routinely do molecular path not only in breast but lung cancers and other solid tumors, and then you have these biopsies. So in our hospital we have moved to needle biopsies now in breast cancer, right? So that is required for histopathology, it is required for ER, PR and HER2 IHC, and then it is required for molecular pathology. Previously what would be done was that you've done your H&E, then you need IHC, you cut more sections. Then you need molecular path. When that is ordered of fish, you cut more sections. Now what happens there is loss of tissue. So the new guideline is, whenever you have a potential tumor tissue on which you will have to do fish or molecular studies, take multiple sections right in the beginning. Because every time the technologist goes back to cut sections, there is loss of tissue, right? And this is what I say, we have to realize the more we take, the less we are going to have, right? And this is a big issue when you start doing molecular path on solid tumor cases. Now what happens is slide preparation. So basically for fish, we coat the slides with polyl lysine. Now what I want to show here is, if you look at this thing, right, this is a block. Now there is a common practice in histopath pathology labs wherein they put the tissue in eosin and then embed it in the wax block so that the technologist can see the tissue. Now the problem with this eosin is it causes a lot of background noise. So when you start fishing them and you do fish on it, there is so much of background noise, it is very difficult to interpret, right? So one of the ways is you can actually reduce the amount of eosin you dip your tissue so that it becomes just light yellow color, enough for your technologist to see. Now I remember I got a call from Bangalore once, and this guy was like, our HER2 fish on MRM specimens, radical surgery is working, but on biopsies it is not working. Because in the radical surgeries, the tissue size is big, so nobody dips it into eosin. But the small tissue biopsies, they dip it into eosin, and that causes a lot of background noise, very difficult to interpret, right? So whenever you have a lot of noise, what do you do in life or lab? You go to alcohol, right? So one of the ways of getting rid of this noise is you take the slides with this eosin and you dip it in alcohol 4 to 5 hours, and the noise will go away, and then you can start fishing these slides and look for HER2 fish. So it's technically very demanding. There are a lot of pre-analytical factors here. You have to have proper fixation. You should have buffered formalin. You should have good quality xylene. And we really suffer. Sometimes we do get blocks from outside that have not been processed properly. And if your fixation is not right, you will not get proper, and you cannot do any molecular test on the tissue, right? So it's a very technically demanding. It takes 3 days. So you get a section today, and day after tomorrow you can start reading the fish for these patients. So what are the pre-analytical? Time to fixation, quality of the fixative, time of fixations, right? Even over fixation is a problem. Specimen storage, the way it has to be stored, storage time for blocks, it's all there, you can have a look at it. Storage condition, and for about 4 to 6 weeks old sections we can take. And decalcification is a problem, because when you do decalcification using acids, your DNA gets disintegrated, right? And then it's very difficult to do any molecular tests on that. So you can use very light EDTA based defixation instead of using very strong and harsh acid based decalcification in these patients. So this is how the fish probe looks. You have the centromeric red and the HER2 green. It depends on the company you have. You can always have other way around. And never look at DCIS, because when DCIS is usually HER2 positive. So whenever you are doing HER2, you have to look at the invasive component, right? So what we do is, when we do fish, we look at the HND, we look at the IHC, and then have that mental picture, and then go back to the fluorescent microscope, and then you read, because you only have to read the invasive component, not the DCIS. Now, there can be various patterns, right? So, see, this is chromosome 17, and you can see there is polysomy. Even though you have multiple copies, you take the ratio of the HER2 signal versus the control signal, right? So, this is not amplification. Sometimes the control can amplify, not the gene itself. Sometimes you get polysomy with amplification of the HER2 gene, and sometimes you have gain, and so you get multiple patterns. So all you need to do is, we usually have 2 different readers who read this fish, and that is validated by the third person if there is any discordance. So it has to be done very meticulously, and there is a lot of, you have to be very careful about tumor heterogeneity. So I'll give you simple examples. We had 3 core biopsies from a patient, right? So my fellow student saw and said, sir, it is negative. 2 cores were negative, the third core was completely positive, right? So you have to see all the cores, you have to examine the complete tumor tissue, right? That is very important, because what may happen is, also you must understand that once you treat this patient because of tumor heterogeneity, suppose there's a HER2 positive patient, you've treated, patient relapses later and comes as HER2 negative. And we had this case where the patient sued the medical oncologist that it was HER2 positive, I'm relapsing as HER2 negative. It is absolutely fine biologically, because now you have targeted the HER2 positive cells using Herceptin. And then these HER2 negative cells have got this opportunity now to grow, and there's not much competition for them. And so you can have HER2 positive tumors relapsing as HER2 negative. So there is a lot of tumor heterogeneity, and when you do this, you realize that there are cells which are positive, there are cells which are negative, and at least 10% of tumor cell population should be amplified to call it as HER2 fish positive, right? Sometimes what we do is, when it is less than 10%, we put a note there. HER2 is negative, however, 5% of tumor population is seen which shows HER2 positivity. These patients would not benefit from Herceptin therapy, but later if the patient relapses as HER2 positive, then that information is there, and we can say, okay, there was this small tumor population, the majority was HER2 negative, but there was a small tumor population which was HER2 positive, and that is why we have to record those observations when we report in this. So this is how it looked, positive, low, and now what has happened is, there is a new thing that has come, and this is the recent update after the Destiny trial, wherein you have HER2 ultra low, right? So first we only had to do HER2 positive and negative. Now on IHC, you have something called as ultra low, wherein 0 with faint membrane staining in less than 10% of tumor cells. And HER2 low, IHC 1 or 2 plus with negative in situ hybridization. Why I'm saying is because now there is a new drug for this patient. So even if you are HER2 low, you can be treated. So what has happened is HER2 low, now you have trastuzumab deruxtecan. So what it does is it combines with standard therapy and it is able to deliver the drug even when you are HER2 low. So as histopathologists, now the responsibility has increased, right? And now the histopathologists will have to really look at the HER2 IHC in a much better way and then try to classify them further as HER2 low and ultra low. And believe me, it is not easy. Even now, our pathologists are kind of working their way how to call HER2 low, ultra low, and so on. And there has to be a consensus uniformity when you look at it. And that will come only with practice. What do you call HER2 low and this? There is no fish counterpart to HER2 low or ultra low, but the responsibility of the histopathologist now is much more, and they have to look at this and identify this. Now, having done that, let's talk about the germline mutations. Now, we know that whenever you have, there's a whole lot, we only talk about BRCA1 and BRCA2, but there are a whole lot of genes which are involved, right? And all of these genes are involved in DNA damage repair pathways. So we get RAD51s, the FANG genes. So what we do is we do a next generation sequencing, NGS, and we look at the whole panel of these genes, which is hereditary gene panel, and try to identify mutations. Now, it's a very challenging area. You need to have a dedicated genetic counselor who counsels the patient before the test, counsels the patient after the test reports. And also, see, there is a lot of anxiety involved, right? Suppose you get a mutation, then you will have to even test your family members. So it is not just mutation. Sometimes you also get copy numbers, deletions, which can be missed by NGS. So you have to do some other technique. It's called MLPA, wherein you look for a deletion of a portion of the BRCA gene. Now, all of this has to be integrated, right? The patient has to be counseled before the test, after the test, and if you find a mutation, the daughter or the sister or whoever have to be checked for that specific mutation. Because it not only increases the risk for breast cancers, it also does increase the risk for ovarian cancers. One of our own nurses in the hospital, somehow I don't know why she didn't get this test done, and she had a breast cancer, and later she comes back with an ovarian cancer, right? If she would have got it done, we would have done prophylactic oophorectomy right in the beginning. And ovarian serous carcinomas are very bad. They have very bad prognosis. So it is an area in itself, right? And we have to look at all of these genes, and there's enough in literature. You can go and look at these panels. There are panels that are available, and we do NGS to identify this. And we're getting a lot of patients positive, and you also need to take family history. So they will have family history. Okay, my maternal grandfather had a colon cancer or had some other cancer. So the complete family history has to be taken, right? And once you've taken the family history and this patient has breast cancer, you need to test. Even if the family history is negative, sometimes you can have the BRCA mutation de novo. The patient could be first time index patient, and then that mutation could go on to the next generation. So that also has to be taken care of, right? So these are, as I said, DNA double, and we also do somatic. So one is germline, so you do it from the blood. One is somatic. So somatic means the mutation is present in the tumor cells, not in the germline. So the somatic one may not have increased risk of cancer, but these are the candidates for PARP inhibitors. And so you can give olaparib and talazoparib for these patients, and these patients do well when you have this BRCA mutations in the somatic, in the tumor cells, not the germline. Now, what has happened is with high throughput technologies, we've been doing so many sequencing, right? And we've been identifying a lot of mutations. And as driver mutations are being identified, the pharma industry works to develop drugs against this. Now, some of these mutations that have become more important, significant recently are the PIK3 mutations. So over 30 to 40% of breast cancer, and they do have a drug for them. And we have the GATA3. So for the PIK3, we used to first do a single gene assay, wherein we just developed a Sanger sequencing just for PIK3. But as the demand has increased, we now kind of do it in next generation sequencing panel, where we look for any possible PIK3 mutations in all breast cancer patients. So what is PIK3? It is one of the most frequently mutated it is involved in the You can see it is involved in the PIP2 AKT pathway, activation of mTOR and proliferation, right? So these mutations are most common in HER2 positive and both HER2 negative, activates the mTOR pathway, promotes cell proliferation, and now you have a therapeutic PI3K inhibitors, right? So now we have been able to quite a few of our patients are able to afford, and those, as I said, we had this compassionate drug access program. Patients are being treated for this. Another mutation which has come is, these are all recent updates, are the ESR1 mutations. Now ESR, what it does is it encodes for the estrogen receptor. So once a patient is ER positive, right, you start giving hormonal therapy. Now some of these patients stop responding to hormonal therapy, and or they do not respond to hormonal therapy even though they are ER positive. And when you go and sequence them, you find this ESR1 mutation, right? So these are enriched in metastatic ER positive HER2 negative cases. So you have a ER positive HER2 negative patient presents with metastasis, could be a candidate for ESR mutations, and you can check them. Now, as I said, there is endocrine therapy resistance for this patient. What can also be done is a liquid biopsy, circulating tumor DNA for these patients. So we have been doing liquid biopsy for lung cancer patients now. We are trying to develop this test for ESR for these patients who are ER positive and not responding. So liquid biopsy is circulating tumor DNA. So what is circulating tumor DNA? So the tumor cells keep dying, right? They keep undergoing apoptosis. So when they undergo apoptosis, the tumor DNA is released into the blood, and then you can extract that tumor DNA and you can do sequencing and find out the mutation. So we do this for EGFR mutations. We have had patients, I remember a lung cancer patient who had metastatic brain tumor. We could not go back to the brain, it was not accessible. We did the circulating tumor DNA, we found the mutation. We could give EGFR inhibitor therapy. So this patient who was in ICU, almost dying, recovered miraculously and walked back home. The tumor would come back sometime again later. That's story of nature, right? The nature has to evolve. It has to find alternate pathways. So the alternate mutations, resistant mutations would come in later. But at least we could send the patient back home and could live for a few more years. So you do have now drugs which are for ESR1 mutations, and these can be given to the patients. Immunotherapy, there are current indications in breast cancers, right, like the PD-L1 positive, triple negative breast cancer and certain HER2 which respond to immunotherapy. There are clinical evidence, and there are future. So this is a more in terms of resistant breast cancers wherein immunotherapy can be done and PD-L1 is tested. Now, having said that, we know different histopathological subtypes of tumors, but they do also have molecular subtypes. And there is a correlation between the molecular subtypes and the histopathology and the kind of mutations you see in these patients. So you have these are the molecular subtypes, luminal A, B, basal-like, and HER2E. And you can see that the luminal A have more common in triple negative, they have PIK3 mutations. Luminal B have TP53 mutations, the basal-like have TP53 and retinoblastoma mutations, and so on. And they have their own prognostic and predictive indicators. Coming to the multi-gene assays, as I said, these are very expensive tests. We don't do them ourselves, we outsource them. It gives a recurrence score. Mama print is 70 gene, high versus low genomic risk. And then you have the EndoPredict and ProSigna, which is prognostic for late recurrence beyond 5 years. So it helps us to identify patients who can safely avoid chemotherapy, improves risk stratification beyond standard clinical pathological. So once you know, based on these results, you get a score, and based on the score, you can know whether this patient you can avoid chemotherapy versus this patient would be a candidate for chemotherapy. So why molecular testing in breast cancer matters? Well, it has prognostic value, it is predictive, treatment personalization, you can do tests to identify resistance mechanism, and of course, as I said, the hereditary cancer risk is a huge field in itself. We have now a genetic counselor for hereditary cancer, not just breast, but for other tumors also in our hospital. So to summarize, yes, it's a heterogeneous disease. It's classified into molecular subtypes which have distinct biology and prognosis. The key biomarkers other than ERPR, HER2, we have PIK3CA and PDL1 and BRCA1 and BRCA2. Molecular testing, IHC, FISH, and I think the day of single gene assays are going now. You have to do multiple gene assays, and that's where next generation sequencing comes into play. We have been using it. It's essential for diagnosis, risk stratification, and targeted treatment. There are targeted therapies, the HER2 directed PARP inhibitors, PI3K inhibitors, and CD46. There are immunotherapies, and I think as we go ahead and once we identify more such mutations, we could use liquid biopsy to identify resistant mutations in patients who are not responding or showing resistance. With that, I would like to acknowledge all the patients and families. This is where we learn from, all the colleagues from clinical staff, all the staff of histopathology and molecular path. This is a lab hemat team, that's Dr. Mishra, lab director. This is our cytogenetics team. This is during Durga Puja, wherein all of us were, and I don't know, I've been observing somehow that the women always wear black and white like chromosomes, and the men are like fluorescent bright colors. I don't know why that happens. And these are my old students who have done fellowship with us. They keep asking me questions, keeping me on my feet, and I get to learn from all of them. Thank you for your hearing. I'm happy to take any questions.
Thank you, Dr. Mayur sir, for this wonderful presentation. And I hope that most of us have been able to understand, because I think he has spoken from the basics. I have attended few of his lectures, and believe me, this was the most basic one because otherwise, I think many of you must have played cricket. So most of the time, these are bouncers where people have to duck down so that the ball goes over the top. So thank you very much, sir. We would like to have some questions from the floor, if there are any. I know Dr. Adarsh has joined us just now. So maybe would you like to have some questions on breast molecular testing, anything in relation to that which you find in your patients that is worrisome?
Yeah, currently I think most of the molecular studies currently it's not available, right? Are you outsourcing?
Yeah, we are currently outsourcing it, but we intend to start in-house.
Okay. So it will be exciting. Yeah. Sorry, I didn't. I just came now.
Okay.
So I didn't hear your presentation.
No, so I kind of summarized about hormone receptors, then HER2, right, and then the BRCAs, both somatic and germline, and the newer PIK3 ESR1 mutations and immunotherapy, and that's how we work about. And it has been a challenge even for us in India in terms of making these tests available in an economic way, right? You need economies of scale. You need larger number of patients in order to do it in-house, because otherwise it becomes pretty expensive. What we have done is we kind of try to multiplex, because we do different tumors in the same run on NGS, and that is how we have been able to offer it to our patients. In terms of germline testing, to be honest, we also outsource them because we do not have that many numbers which come in wherein we can keep running it every week and giving reports, right? So I think molecular pathology, yes, we have to look at what is essential, but at the same time, we have to look at the economies of scale, right? But we do have in-house mechanism, even though we outsource some of these germline in terms of genetic counseling of patients, pre-test counseling, post-test counseling, and also then testing of the relatives of those that have these germline mutations. And we have to keep an update, because what happens is today a variant which is variant of unknown significance tomorrow becomes pathogenic. So after 3 months, when the genomic data gets updated, so something which was non-pathogenic mutation later becomes pathogenic mutation. So you have to recall the patient back and then tell, look, this is happening, and then we need to take actions based on that. So it's a very intensive, continuous process, and a whole team of people are involved in it.
Thank you.
Yeah.
Any other questions from the floor, please?
Actually, I have a query not related to this.
Tell me now.
Actually, I am a urologist. I see a lot of patients having cancer prostate.
Uh-huh.
And here in Africa, we see patients having very aggressive tumor. They come at the age of around 42, 45. So I just want to know from you, are there any markers we can do or genetic testing we can do so that we can help them?
Yeah.
Because you see in the lake belt of Kenya, that is on the western side, there is very aggressive tumors. They come at the age of 45 with a PSA of more than 100. I think Dr. Rao also knows because we deal with a lot of biopsies and all. So I want something from your side which we can do here. We can help those patients to identify early. And the prognosis, the way it is aggressive tumor, how can we help them so that they can be treated in a very nice way?
Very nice. So, for prostate, we also do the BRCA for them, right? And these patients which are BRCA positive do respond well to PARP inhibitors. So that is one. In our center, in terms of prostate, we don't do much molecular path, to be honest, except for the BRCA and things. But I think with new therapies, especially how do I say, the anti-testosterone, the hormonal therapies. So we've been, our medical oncologists have been able to handle stage 4 prostate cancer with metastasis with almost more than 10 years survival. And so now prostate is not very worrisome in terms of the therapeutic options that are available. So of course some drugs are expensive there, but because my medical oncologist is he's very good with prostate cancers. I mean, he's one of Dr. Deepak, who's an expert in this. And we have had stage 4 multiple metastasis. They've been alive for more than 10 years now, and he's been able to handle them. Yeah.
Anything related in genetic markers which we can?
Not much for prostate. Not much for prostate as of now. Yeah, it's evolving. Maybe we find.
Any other questions from the floor, please? Johnson. Yes, please.
So, Dr. Mayur, welcome to Kenya.
Thank you.
Thanks for sparing your time and giving us a wonderful presentation. Very useful, and I deal with breast cancer, and the journey started long back, and the first molecular marker was ERPR, and from there the journey started, and now it is a journey into indefinite direction. We have several patients where still we are, even with NGS, we have not identified. One patient is 39-year-old woman, first breast cancer, 6 years later ovarian cancer, NGS, VUS. Another doctor's relative, 3 siblings, mother and grandmother, all breast cancer, again VUS. So as you said, that VUS may become VUS today, but tomorrow again that VUS may convert into something significant which can target. Challenges in Kenya are again treatment related, cost, even the testing. But Oncotype DX, I found it very useful, and I consider Oncotype DX actually financially affordable. The reason is not because here we have rich patients, but when you save patient from chemotherapy, especially when Oncotype DX is recommended in node negative, ERPR positive, so it removes quite a bit of burden of the patients from there. And if we can save patient from unnecessary chemotherapy, first of all, it saves chemotherapy cost, which is also quite a bit, and then it saves costs from toxicity related to chemotherapy. So in my personal practice, I can try to convince.
Absolutely.
But it's still really, really very expensive.
It is.
I expect answer for more affordable tests will come from countries like India eventually.
Yes, so we've been trying to, there's one on the Roche platform we're trying, which kind of gives similar information, would be much cheaper. And believe me, the resource constraint is a challenge in India also. We have all kinds of patients. I mean, there are patients who can afford the moon, and there are patients who really can't afford much. And it's a constant challenge for us also in India. Yes.
So my question to you is one is, When patient comes with breast cancer and close immediate relative has either breast or ovarian cancer, would you recommend for first somatic mutation or we go straight for germline?
No, would go straight for germline. Yeah. See, because somatic, I mean, even if you do somatic, you'll pick up the germline. I mean, because a germline mutation is there in all the cells of the body, right?
Right.
So even if you just send a tumor, you will be able to find that mutation. And so whenever you do a somatic sequencing, and suppose you see a mutation which is like having a variant allele frequency of 90%, 100%, or 80%, anything more than 50, 60%, it's probably germline. But then you may have to repeat it in germline,
Right, yeah.
to confirm that it is germline, and then it's again a cost there, right? So with the family history, you do the germline for sure, and because it's not just the BRCA1 and BRCA2, I mean, there's a whole lot
Yes,
it
that's
is a
right.
whole group of genes there, the RAD51s, the FANK-A, FANK-Bs. So there's a whole lot of genes. So we do that. That is how we approach it there.
But wouldn't that increase the cost? First you do germline and then,
Yeah,
first you do somatic and then.
It would. So if you have access to PARP inhibitors, then it makes sense. I mean, if you do not have access to PARP inhibitors, then somatic would, because that is where it comes into play.
Thank you.
I think in one of our patients we had the same challenge.
That's right, yeah.
I think I have one question for you. You told about when we have ER positive breast carcinomas which are not responding to treatment, and of course the TNBCs. And in the NGS, so should we go for a whole exome sequencing or whole genome sequencing or exome sequencing if we want to go for NGS?
No. So again, as I said, depending on the question you are asking. So if you have a ER positive or something which is not responding, as of now, we do not do whole genome. We do have a panel, right? Say 55 hotspot gene panel and things like that. As of now, we've got a research grant funding to do whole genome in breast cancer patients. We're going to start that, but that's going to be on a research mode because it costs a lot of money, right? But as the technologies become cheaper, it may be the next option where you do whole genome, because you will not only identify in whole genome the somatic mutations, you will identify germline, you will identify copy number, and you will also identify polymorphisms which are important for drug metabolism. So it will give you a much more information. So in UK now, somehow NIH has given a lot of money and they are doing whole genome for every tumor, and based on that they are modifying the treatment. So we wrote a grant and we have got some funding, but with the funding we can only do 25 patients. So we are going to do it as a pilot and see, because doing whole genome and delivering it, we have to work it out, the whole process, right? The time, the duration, within 2 weeks, can we get the reports out and things like that, and work on that. And then, but whole genome is being used. Yeah. So that's a call.
So of course, I think whole genome cost is the main constraint. Otherwise, that is the best.
Yes.
So I think before this talk of ours, we were in a workshop at JW Marriott where Dr. Mayur spoke about nanopore technology. So Oxford nanopore NGS is now, of course, in the Kenyan market also. And they are mostly based, I think, focused on infectious diseases as of now. But they are working on solid tumors also.
Yeah.
So
So Oxford nanopore, the advantage of Oxford nanopore is it's a very interesting technology. So what they have done is they have used a bacteriophage and created a small nanopore in a membrane. And then they push the whole DNA through that membrane. And then as the DNA goes through that membrane, based on the nucleic acid, there is a change in the voltage. And then it's real-time sequencing, right? What it has done is it has brought down the cost of sequencing to almost half of what Illumina does, right? So it's short read, this is long read sequencing. The costs are low. The wet lab reagents are much cheaper. And it has been used widely in infectious disease first, because the first sequencer they made was so small, like a pen drive.
it's like this.
You can keep it in your pocket and walk away, right? And you can connect it to your laptop and do sequencing. You don't need to have a big infrastructure NGS lab for that. So because it was a small sequencing machine, it started with infectious disease. It did, in Africa, because it could be done in the fields. You can go and collect the sample, sequence it in the field itself. But now they've had bigger machines, and you can do whole genome, panel, whole RNA. Everything can be done on this, and that will bring down the costs a lot of Oxford Nanopore technology. We are very bullish about it and looking at it now.
So one last question, sir, before we end up. What is your take on if like Jalaram Medical Services wanted to go for an Oxford Nanopore? Of course, they are working still on solid tumors, and I believe that they do something good on it in the next 6 months. Is it the correct path to go, or should we go for Illumina?
Okay. So the problem with Oxford Nanopore is the formalin fixed paraffin embedded, they have not, still standardized. It's Oxford Nanopore can be there for your leukemias. It's great, but for solid tumor, then you will need fresh tissue. So before FFP, so if you could extract nucleic acids from fresh tissue, you could still use Oxford Nanopore. But that will again be a logistic challenge, right? Collect it from the operation theater immediately, snap freezing it and extracting your nucleic acid. So as of now, Oxford Nanopore for solid tumor is still a challenge because its FFP cannot be done on that. Let's see, they come up with solutions. It's a new company and they're evolving pretty fast.
I think for the fresh tissues, Dr. Chauhan and his colleagues will help us if you want to introduce that. Thank you so much, Mayur sir. It was a pleasant talk and it was very informative for all of us. Just to let everybody of you know that Jalara Medical Services is now capable of doing ER, PR, HER2 and Ki67 for the breast receptor markers. We have priced it as we are famous for at a very baseline to help the society and patients at large. So I would request all of you to send your cases here and we will be able to report them out in 5 to 7 days as of now. So as the numbers increase, the time also will be minimized. But right now what we are looking for is volumes. So we look forward for your support and of course so that the community can be helped at large. This is our motto. Please help us do that thing. Thank you very much. So I think we can proceed for lunch and thank you once again, Mayur sir.
Thank you for having
your
me.
valuable time.
Thank you so much. Hello, sir. Mayur, sir.
Romeo Suarez,
Hello.
GP over there.
Thank you so much.
No worries.
Yeah, so these patients, we have many patients with
all treatment exhausted. Nutrition therapy, sort of whatever. These we can try. We have to start. Half inhibitors are available.